We're all taught about dysphagia from an acute care lens. So you see a patient, usually an adult that's had a stroke. They need an assessment while they're in hospital, and then we need to give recommendations that are usually temporary and don't take a person's home environment into account. That does not work for clients at home with chronic dysphagia. There is a difference between dysphagia management in acute versus in the community, and there is a gap in our training and in continuing dysphagia education, and I don't think we talk about it enough. And because we don't talk about it enough, community speechies are left thinking they're doing something wrong. There is just something really special about seeing people in their own homes, meeting their family, seeing their pictures on the wall, sharing a cup of tea with them, and just having the privilege of listening to their stories and getting to know them in a way that's really hard when they're in hospital.
So where does this research come in? Research bites.
Welcome to the Dysphagia Research Bites podcast, which is a podcast designed to make dysphagia research more clinically digestible for speechies, especially those working in home and community-based settings. My name's Chantelle, I'm a speech pathologist, and I started this podcast because dysphagia care doesn't just happen in hospitals. It happens around kitchen tables, in aged care facilities, and in everyday life. Community dysphagia work is complex, it's nuanced, and it's often underrepresented in conversations about swallowing. So, if you're looking for clinical tips and thoughtful, evidence-informed conversations that actually translate to practice, you're in the right place. So, this podcast episode is going to be a little different from other episodes, and I'm a little excited about it. If you're a regular Dysphagia Research Bites listener, you'll know that a typical episode is where I interview either a clinician, a researcher, or sometimes a special unicorn, clinician and researcher in one, and we talk about a specific dysphagia topic. Today, I'm flying solo. You've got just me, and I'm going to be talking about what I call the 8 principles of community-based dysphagia care. And I've got a little bit of a backstory for you in how these principles came about and how I actually went from being adamant that I didn't want to work in the community to not really wanting to work anywhere else. So it all started back in 2013. Don't worry, you don't have to pull up a chair. Give me 5-10 minutes tops. In 2013, I'd been qualified as a speechie for 3 years, and at that time, I'd only worked in hospitals, but I was looking for a change. Not a change in job setting, but a change in country. You can probably tell by my accent that I'm from Australia, but I'd always wanted to travel overseas, and it was well known that Australia and UK have this working relationship. Officially, I think it's known as a mutual recognition program set up, so it was quite common for Aussie therapists to go have a stint in the UK and vice versa. So I decided sometime around the start of 2013 that I was going to move to the UK. So that year I spent saving and preparing to travel. So the trip I had planned, it wasn't just a straightforward Australia to London trip. My mum and I had planned a trip to Uganda first because a lady we knew had set up this program and they needed volunteers. So we decided to do that for a couple of weeks. But then we figured, well, we're traveling all the way over to Africa because, Australia is not close to anything. Well, we may as well go to Egypt because both of us had wanted to go to Egypt since forever. And when I was little, I wanted to be an Egyptologist, and I tried to teach myself how to read hieroglyphics because I thought that was the coolest thing ever. Anyway, I was not successful with that, so naturally, I decided to go into speech pathology. Anyway, Mum and I did Egypt. It was amazing. We said our goodbyes and then I moved to London. I'd already signed up with a recruitment agency when I was in Australia, so I just gave them a call and said, okay, I'm in London now. Hi, Ben, if you're listening. And I told Ben, do not put me in a community role. No, I think I said it a little bit nicer than that. But I was adamant that I didn't want to work in the community because I'd been working in inpatient rehab and community roles had a stigma attached to them back then. They were viewed as less than compared to inpatient positions. And I think they still do have a bit of a stigma. So Ben comes back to me and would you know it, he says, oh, sorry, Chantelle, but the only available position is a community role. Yeah, okay, Ben. I kind of didn't believe him at the time. I was sure he just said that because those positions were harder to fill. So I don't know. We might never know the truth. Ben, if you hear this episode, please leave a comment on Spotify. I would love to know if you were telling porkies. Anyway, I took the role because I didn't feel like I had much of a choice. So I was actually working as a waitress at the time because there was a delay in getting my registration through. And my wage at the time, I kid you not, it was, I can't remember exactly, it was either £2 80 pence, I think it is over there, or £3 80 pence per hour. Whatever it wasn't enough to pay my rent. So I took that community role. Another thing about that role was that it was in the northern part of London and I lived in the southern part. So for any Londoners listening, you'll know that traveling all the way from Tooting Bec to Enfield every day is a 3-hour round trip. Now it sounds brutal, but it was fine actually, because I was on an adventure, guys. I was in my 20s, I was carefree, living my best life. It was great. And I had a great album to listen to, which I listened to on that same commute every single day for months. For anyone who's curious, the album was Sam Smith's In the Lonely Hour. And whenever I hear a song from that album to this day, it really takes me back to that particular time in London. And the memories are not just about me sitting on the tube going to work. Those memories are also about a young man that I met when I stopped in Egypt. So I left that part out of the story, but in my 2 weeks that I visited Egypt with my mum, I actually met a young man. So he was 24 and I was 28. Don't do the maths and figure out how old I am, please. But, he was very special. So he was on my mind a lot at that time, and I actually delayed my trip to London at the end of my holiday and ended up staying in Egypt another month just so I could get to know him a bit more and meet his family, etc. Anyway, went off on a bit of a tangent there, but the reason I mention that is because that Egyptian man was not the only thing I fell in love with at the time. I fell in love with community-based work as a speech pathologist. And in fact, I ended up going back to Ben after being in that role for a few months, and I said, do not put me back in the hospital. Now, I know a lot of speeches out there will relate. There is just something really special about seeing people in their own homes, meeting their family, seeing their pictures on the wall, sharing a cup of tea with them, and just having the privilege of listening to their stories and getting to know them in a way that's really hard when they're in hospital. I still remember a lady in the UK who sent me home with that big bag of lemons, and I still remember this Armenian mother in Melbourne who would always make me sit down and have a cuppa and some of her homemade biscuits. The kindness and the warmth from clients and their families, there are so many stories that just stay with you. So that's one way community practice is different, but there are so many other ways. And it was, during this time in London that I really discovered community-based practice is just a whole different ballgame. Fast forward for 5 years. And it's 2018. I'm back in Australia. I've worked in community and some outpatient roles, but it was the end of 2018 I took on my first senior role in a community private practice. And it was the first time I started seeing adults with developmental disabilities like cerebral palsy and intellectual disabilities. Now, I felt confident in my dysphagia skills at that time, so I'd been working for about 7 years. But then I saw a young man with cerebral palsy, a severe to profound intellectual disability, and a peg tube. And I observed him during a meal where he was being assisted to eat puree food and moderately thickened fluids. And I was shocked by what I saw. His swallowing, it looked so bad. There were risks everywhere. What's going on? I can't do a cranial nerve exam. I can't do a structured assessment. The validated tools that I've used before, they are not appropriate here. What do I do? What do I even document? I was seeing these really idiosyncratic behaviors that I'd never seen before. And that's when it hit home for me. I already knew community-based work was different, even for adults with stroke and progressive neurological conditions. I'd done a lot of rehab in the home, but then working with adults with developmental disabilities in group homes, working with care staff, working in, aged care, totally different again. So I went looking for dysphagia education that would help me as a speech pathologist working in the community with a diverse caseload, and I couldn't find anything. Anyway, that led me to develop the clinical swallow evaluation course for community practice, and it was through putting that together, reading the research and reflecting on why it's different, that I realized we were trying to apply these acute care principles to a community-based setting. So I started to write down these acute care principles and I started working on the course, and that naturally led into these 8 principles of community-based dysphagia care, which are mostly the opposite of these acute care principles of managing dysphagia that typically we're taught. Now, because I previously had a management role where I was involved in interviewing and supporting a lot of new graduates, I saw that the dysphagia training still seemed to be pretty much the same as when I graduated 15 odd years ago. So I thought it would be helpful if I pull this chapter from the on-demand course and make it a podcast episode. So like I said, it's a special episode, and I hope this makes things a bit clearer for a lot of therapists out there. So this topic, it essentially sums up my whole business and why I started it. It's why I started Dysphagia Community on Instagram, and it's why I started this podcast, because there is a difference between dysphagia management in acute versus in the community. And there is a gap in our training and in continuing dysphagia education. And I don't think we talk about it enough. And because we don't talk about it enough, community speechies are left thinking they're doing something wrong. But a lot of the time, it's because they haven't been prepared well enough. We're all taught about dysphagia from an acute care lens. So you see a patient, usually an adult that's had a stroke. They need an assessment while they're in hospital, and then we need to give recommendations that are usually temporary and don't take a person's home environment into account. That does not work for clients at home with chronic dysphagia. But, as therapists working in the community, we still want to provide an excellent standard of care. We want to use validated tools. We want to understand the research as it applies to a community setting. And we want to develop a solid management plan that's grounded in evidence. So let me start by just naming these acute care principles that we've been trying to apply in a community setting, so I can then introduce the 8 principles of community-based dysphagia care. Number 1, the first acute care principle I have is that the purpose of assessment is to identify if dysphagia is present. That's not always the purpose of assessment for us in the community. And in fact, I'd argue most of the time, we don't do an assessment for diagnostic purposes. Number 2, everyone needs an instrumental assessment. No, they don't. Or more accurately, that's not feasible. So just telling us as speechies over and over that we can't do anything without instrumentals is not helpful for those therapists who don't have access. And even with access, it's not always clinically indicated. Number 3, if someone is at risk of aspiration, they need to be on a modified diet. That's what happens in the hospital a lot of the time, and that setting is built to support someone on a modified diet. It's designed that way. The hospitals have IDSI diets, people in the kitchen are trained, nurses are familiar with IDSI, hospitals usually have signage, it's set up to support that. But think about your patients at home by themselves, their ability to modify diets. What about the standards in the aged care facilities you work at? Those environments are not necessarily set up to support that in the way that hospitals are. Number 4 of acute care principles, and this sort of goes on from the previous point, which is modified diets are the first line of defense in hospital. And like I said, it makes sense in a hospital. It's an intervention that can be applied quickly and easily, and it's usually intended to be temporary. Number 5, speechies tell patients what to eat and drink or clear them for eating and drinking. And I get why this is the case. So people are sick, they're seen by lots of professionals who make recommendations that, although are technically recommendations only, it's generally agreed by everyone that the patient's expected to follow them. Patients can absolutely decline, but we don't usually have a lengthy conversation about each recommendation that's given. In the hospital, the medical model usually still prevails. So, the nurse or the doctor asks us to do an assessment and make a recommendation. Also, many hospitals have dysphagia screening tools. So in the hospital I do some shifts at, any new stroke that comes through, the nurse administers dysphagia screen. If they pass, the patient can eat a regular diet. If they fail, they're put nil by mouth until the speech pathologist assesses them. We don't really have a comparable situation when someone's at home, so the community environment just more naturally lends itself to a social disability model of care rather than a medical one. Number 6, a good dysphagia assessment means a standardized test and a complete cranial nerve exam. I think this is so important in an acute setting, and this is how I do my clinical swallow evals as much as I can. In the community, if you're only doing a standardized approach, you're going to be missing a lot of the important information, and a lot of clients with cognitive impairments won't be able to follow instructions to complete a cranial nerve exam, for example. Number 7, the goal is to eliminate all signs of dysphagia. When you work in a hospital setting, the vast majority of dysphagia cases that you see are from acquired injuries like stroke, and generally the primary goal is, fix the dysphagia. For our clients in the community, that might be the goal, but for most, they have a chronic dysphagia that's not fixable, and so targeting swallow physiology often is not the primary goal. And 8, the recommended diet and fluid consistencies should be based on video fluoroscopy results. So when I work in acute, I don't like to recommend modified fluids without instrumental, and I think when patients are in hospital for rehab, it makes sense to let instrumental examinations guide diet and fluid consistencies, but not in the community. Okay, so let me talk you through these 8 principles of community-based dysphagia care. Principle 1, the clinical swallow evaluation is a comprehensive assessment. So in the community, the clinical swallow eval is often the primary assessment. We're not only looking at swallowing safety or inferring it as best as we can, we're looking at positioning, fatigue, carer support, the mealtime environment, and functional eating patterns. So while instrumental assessments provide valuable physiological insight, they're not always available or even necessary depending on the client's goal. So this is reinforced in Simone Howell's article from 2019, which showed that community practice demands adaptation, with the CSE providing a more holistic, context-driven picture of swallowing. Unlike acute settings, speeches in the community often have more time to observe a full meal, and we should when we can, because this gives us important information to help guide long-term and not just short-term management. So when we observe an entire meal rather than just a few bolus trials, we gain insights that we just otherwise wouldn't get. So for example, psychosocial factors. A full meal time allows us to see how clients interact with family or support staff, how much independence they can safely maintain, and how important food enjoyment and social participation is to them. Volume and nutritional intake. Observing how much food or fluid a client consumes in real time informs whether their nutritional and hydration needs can realistically be met on their current diet. These are the kinds of insights that can't be captured in a rapid, acute-style swallowing screening tool. And don't forget, the clinical swallow eval, the CSE, is not just the swallow trials, it's the case history as well, which is so much more important in the community, knowing how the dysphagia is progressing, when it might fluctuate, strategies they've trialed that are helpful or not. In the hospital, often the dysphagia is new, so there isn't much of a case history. And in the community setting, our assessment is often dynamic and we're changing things and recommending things based on what we see. Maybe not in the first part of the assessment, because often we just want to see how a client manages without us interfering, but then it often turns into more of a dynamic assessment as we make suggestions and observations. Okay, the second principle, the assessment should be highly individualized. Firstly, because as I've mentioned before, the reasons for doing an assessment are multifactorial. In acute settings, the goals are usually about diagnosing dysphagia and determining aspiration risk. In the community, there are lots of reasons for the assessment. Yes, it could be to diagnose dysphagia and determine aspiration risk, but it could also be about determining choking risk. Often it's because the person needs a mealtime management plan because they have care staff supporting them during mealtimes. Sometimes clients and carers need education and training as well, and that's a primary reason we've been asked to review a person. But on top of that, every person is in a different situation. Some are in a nursing home, some are living in specialist disability accommodation, some are in their own homes. They're not all in a hospital like in an acute setting. The people who support them, they also have different levels of knowledge and skill, and so you'll need to adjust the way you provide education and training. They're not all nursing staff that are assisting the client. Some will be nursing staff if they're in a nursing home, some will be assisted by support workers, some clients by family, maybe even allied health assistants. Also, not all the clients have had a stroke. Some have this diagnosis, but we often see more of a variety of diagnoses in the community setting. And so our approach and the validated tools we use, they'll be different. Okay, the third principle of community-based dysphagia care, swallowing should be assessed in real-world context. So for example, over a mealtime, especially for adults with intellectual or cognitive impairments. We should include the client's usual foods, utensils, and mealtime environment. Also, assessing across an entire meal will allow us to look at things like fatigue, distractions, routines. So it's going to give us the most accurate picture of swallowing safety and skills. When I'm completing a clinical swallow eval for adults with an intellectual disability, I approach this very differently to, say, when I see adults with acquired conditions in an outpatient clinic. So even though both clients are technically living in the community, a clinic type setting is quite different to a client's home or an aged care setting. So if I see adults with an acquired brain injury in the outpatient clinic, the assessment tends to be a bit more structured. I might give more instructions to the client, and in that way, it's a bit closer to how I might approach a CSC in the hospital. And I'd usually only assess in this setting if the client had no cognitive impairment or a very mild cognitive impairment. But if I'm going to assess a client with an intellectual disability or with dementia, I'm always observing first and not giving any direction or instructions whatsoever. So this is important to allow you to properly assess what happens at mealtimes and how carers are supporting that person. Doing home-based assessments also allows us to address practical barriers like meal prep, portioning, and support strategies. For example, I saw a lady post had neck cancer treatment and she also had a past medical history of a TBI. I saw her at home, and doing the assessment there allowed me to see what equipment they had to make a puree diet and how her husband prepared this. So I got him to do that. Now, this lady had a very mild cognitive impairment, and I assessed her in the clinic first. And when I asked her and her husband about meal prep, he said that was fine. He was making pureed food, wasn't an issue. But when I went out there, I realized that it was. So modified meal prep was a barrier for this couple. And so we ended up supplementing some of the home cooked meals with a puree meal delivery service, because all of this cooking and meal prep, it was just too much for the husband to be managing on his own. Another example I have for you is I made the mistake of seeing a client with Down syndrome and an intellectual disability in the clinic. So we'd started a dysphagia clinic at the practice I was working at just to accommodate any urgent referrals, but we did have criteria on who was suitable to be seen at the clinic and who wasn't. And we'd said that it wasn't suitable for adults with intellectual disabilities. But they insisted it was really urgent. And so I said, okay, I'll see him. It wasn't urgent. That probably won't surprise a lot of you. And that happens, but that was okay. But the assessment kind of turned out to be a waste of time. So I guess not okay in that regard. Because obviously funding was used for the session. So in that way, it was a little bit of a waste of time. But this client was in a strange environment, seeing a strange lady, aka me, who was getting him to eat and drink. And his support worker was like, I don't know what he's doing there, but that's not how he normally eats and drinks. Now, I can't remember every detail of exactly what he was doing, but I remember he was moving around a lot. He was doing a lot of bolus holding with the fluids. And essentially that session became more about gathering a case history. And so I had to reschedule the appointment and see the client in his own home, which was much more valuable. Also because he lived with his mum. His mum didn't speak English, but I saw him over a meal and I could see that he ate quite quickly. He was hunched over his food. He got given multiple dishes at once. He had his iPhone resting against a cup so he could watch it while he was eating. And this was a typical meal for him. And I wouldn't have seen all of that if I'd only assessed him in the clinic. Okay, next one. Fourth principle, least restrictive interventions should be trialed first. So said another way, don't go straight for the thickened fluids and the puree diet without considering other things first. Texture modification can support safety, but it shouldn't be the first line of defense. So things like positioning, pacing, environment, mealtime aids, staff training and supervision, support, these things might achieve safety without adding some unnecessary restrictions. Or, there are also some clients that we see that could benefit from dysphagia rehab and improve swallow function. Not too long ago, I saw a gentleman who had a diagnosis of Parkinson's disease, and his fluoro showed aspiration of thin fluids, which was eliminated with a chin tuck. Great. Thing is, he often forgot to do the chin tuck each time, and he lived by himself, so no one to remind him. So he was also offered rehab to see if we could improve swallow function. We ended up doing a expiratory muscle strength training for 5 weeks. And when we did a repeat fluoro at the end of his treatment, he showed improvement on 2 of the objective swallow parameters. So he had faster laryngeal vestibule closure with scores that were clinically significant. So his score moved from outside the normal range to inside the normal range. And as a result, he no longer had aspiration. So now his swallow function improved. He no longer needs to try to remember to do a chin tuck every time he swallows, so a less restrictive intervention. We should also take into account that adherence to modified diets and thickened fluids is not the best. I can't remember the exact statistic off the top of my head. I want to say it's around 50%. And we also need to remember that currently we don't have any convincing evidence that modified diets and fluids prevent mortality and pneumonia. We also need to be aware that thickened fluids carry their own risks as well and can impact on things or result in things like dehydration, malnutrition, reduced quality of life. It can affect bowel habits, and it might increase the chance of a chest infection if they are aspirated. And they're restrictive because being on a modified diet affects your options in terms of what you can eat. So the more modified your diet, the harder it will be to find options you like, especially when going out. Having said all that though, I want you to keep in mind that this continuum of least restrictive to most restrictive is individual. So it's going to look different for everyone. So usually things like postural adjustments, like swallowing with your chin tucked down every time, is considered least restrictive. But for some people, I would argue maybe even for a lot of people, they might find it really annoying and very restrictive to have to do that every time they swallow something, or maybe they don't want to go out and eat because they have to do that. The other thing is, be sure to think about adaptive equipment as well. So for example, rather than recommending thickened fluids because it travels through the throat slower and this patient might be very impulsive and takes large mouthfuls, consider recommending a rate controlled cup instead. Now, I'll admit there are some people, they are a minority, but some people do like thickened fluids. Every now and then you do get someone that's like, oh yeah, this isn't so bad, I like this. So for someone like that, thickened fluids might not feel restrictive at all to them. Okay, so the fifth principle of community-based dysphagia care is around goal setting, and specifically how we think about what success looks like for our community clients. In acute care, the goal is often pretty clear. We're trying to get someone safe, get them eating and drinking, get them home. There's usually an expectation of recovery or at least improvement, and that's what we're working towards. But for many of the clients we see in the community, dysphagia isn't going to resolve. So think about someone with a progressive neurological condition like Parkinson's disease or MND. Think about adults with intellectual disability who have had lifelong feeding and swallowing difficulties. Think about someone in palliative care. For these clients, the trajectory, it isn't about getting better, it's about living as well as possible with dysphagia. And so our goals, they need to reflect that. So rather than framing success as achieving normal swallow function or eliminating aspiration risk, we need to be asking different questions. So questions like, is this person able to eat and drink in a way that brings them enjoyment? Are they able to participate in meals with their family or housemates? Do they feel their feeding preferences and their dignity are being respected? Are the people supporting them confident and well informed in regards to the mealtime support that they need? So this shift in thinking is also supported by some of the research. Again, Howes and colleagues in their 2019 work with community-based clinicians found that experienced speeches working outside of acute care often consciously reframed what success meant. So rather than measuring outcomes purely against swallow biomechanics, they're thinking about autonomy, socialization, and overall well-being. And this is also reinforced by Maloney and Walsh's study in 2019. I'll pop these references in the show notes, who found that speeches working in community settings place quality of life at the center of their dysphagia management, not as an afterthought, but as a central principle. Okay, sixth principle. Carer involvement is essential. So not only in assessment, but obviously in management as well. So for example, if I'm conducting a case history with someone living at home and they have a diagnosis of a TBI or a progressive neurological condition that's impacting on cognition, I always make sure to have a carer present and go through questions with both. Even if someone doesn't have a cognitive impairment, a carer can often offer really valuable insights about things that the person is not even aware of, because sometimes when we're in something or when we're experiencing something, we don't pay attention to it the same way that someone else does. So the carers are essential. I'm very reliant on them as a speech pathologist to not only get really good case history information, but also interpret what I'm seeing in, say, adults who are non-speaking. So I might be, watching a client and see them tapping their chest, and I might ask, oh, do you know why they're tapping their chest like that when they eat? So I might be thinking, oh, maybe it's reflux, maybe something is stuck there. But then the carer says, oh, that's them asking for more, for example. So we should be including carers in assessments, in education, in decision making. And again, in Howes and colleagues' a study in 2019, they emphasized carers as essential to adherence and sustainability. Without their input and capacity, the recommendations are unlikely to succeed. And when I did a research project with students at Melbourne Uni, what came out of the focus groups was a very similar thing. And I just want to say, I keep referencing Howes' study because there is very little research on dysphagia care in the community. Okay, number 7, shared decision making should guide dysphagia care. So in acute settings, decision making is often rapid, it's protocol driven, and it's medically focused with less room for client input as opposed to in the community. Because there's a level of urgency in the acute care setting, and while it's still important to try and be flexible, there are obviously limits to that in the hospital. I also think a lot of patients in the hospital are relying on us to a certain extent to give them recommendations and guide them in making a choice. Now, I don't want to get too far into the topic of informed choice and consent because that could be a whole episode on its own. But as someone who's gone through the medical system, I was initially relying a lot on doctors and specialists to tell me what they think I should do, even as someone with a health background. So just something to keep in mind. But after a period of time living with a certain condition in the community, you often end up with more autonomy. You've got a better understanding of your condition. You're more confident. You're better informed. And so naturally, I think at that stage, people are often in the driver's seat of their care. So community dysphagia care is often long-term. I think it's usually more person-centered and it's deeply tied to quality of life. So in this setting, shared decision-making is essential to ensure recommendations are sustainable, they're acceptable, and they're aligned with the client's values. So like I said before, when someone's been living with dysphagia for a very long time, they're often the expert when it comes to their dysphagia. Sure, we absolutely bring things to the table as speech pathologists, but many clients and carers will know the issues much more intimately than we do. And this is why I love community-based work. I did a 2-day course years ago on motivational interviewing, which is like a style of communication. Highly recommend training in MI, by the way. And it's all about stepping back as the expert as a therapist and instead focusing a bit more on asking the right questions to help guide someone to identify things and goals themselves. So I think this style of interaction naturally lends itself really well in a community-based setting. And then the last principle of community-based dysphagia care. Diet and fluid recommendations shouldn't be based on video fluoroscopy results alone. Now, in the hospital, it's different. I think largely you should be writing the diet and fluid recommendations for inpatients, but for clients or making the recommendations, not writing them. But for clients living in the community, I don't think it's the place of the speechies doing the fluoro in that outpatient clinic, unless they're also the treating speechie in the community. I don't think it's their place to provide the diet and fluid recommendations, and let me explain why. So this decision of diet texture and fluid consistency really needs to be based on multiple factors, not just the aspiration factor, because this is usually how we conclude which is the safest texture for someone. Efficiency comes into it as well. So if there's more residue with a particular texture, we tend to conclude that texture is more risky because there is evidence that a certain amount of residue does increase the risk of aspiration on subsequent swallows. But aspiration is one element. We also need to consider this person's chest history, their mobility, their oral health, their general health. Lots of things should factor into this final decision of what this person is going to eat and drink. Some people argue, well, the speechie doing the video fluoroscopy should take these things into account as well when they make their recommendations, but I don't think it's feasible for that speechie to know that client and their situation in that level of detail. I think the speechie doing the fluoro should have expertise in doing the fluoro and interpreting the fluoro. The treating speechie in the community should have expertise in their client and their client's situation. And I kind of think of this like when a GP refers their patient for a radiology procedure. So the GP wants the results of that procedure. They don't want that radiologist who doesn't know their patient giving that patient a plan. That's also not fair to the radiologist. It's not their job. They don't know the patient and the patient's situation. That's the GP's job. And that's a community-based speeches job, in my opinion. So we know that the video fluoroscopy fees provide biomechanical insights about the swallow, but they don't capture lived eating experiences. So we need to consider those as well to make sure that the recommendations we give are realistic, but also person-centered. Okay, so those are my 8 principles of community-based dysphagia care. I hope that information has been helpful for some of you. And for anyone who was curious about that Egyptian fellow, well, we ended up in a long-distance relationship for 2 years, and then we got married and now have 2 kids. Thanks for tuning in to the Dysphagia Research Bites podcast. If you want more dysphagia education, then head over to Instagram at Dysphagia Community or www.dysphagiabites.com. Bye-bye. I stuffed up my chopsticks.
One thing that you